I mentioned a while ago that since the 1950s, the standard has been lobectomy for patients with early-stage lung cancer. There are 3 lobes in the right lung and there are 2 on the left. So you take out one of those lobes with the lymph nodes around it. The question came in is, how many lymph nodes do you take out and what's important? And the Japanese have done lots of work on this and have felt that if you go in and take all the lymph nodes out of the chest, they thought that that would increase survival. So we completed a national trial in North America and Canada on over 1,000 patients where they were randomized to a lobectomy with either just sampling, which means just taking one lymph node out of each area of the chest, upper, middle, lower, versus taking them all out. The primary objective was to look at survival and see if there's a difference. And what we found was not only was there no difference in survival, but there was no difference in morbidity or complications if you just sampled the nodes. Now, this means you need to sample a lymph node from 8 different positions in the chest, but you don't necessarily need to take all the lymph nodes out if it's an early-stage patient. So this has definitely changed our care. The other advance has been in the minimally invasive approach to lung resections. My partners and I got together and had a consensus conference in 1998 with leaders around the world who were starting to do these thoracoscopic, which is using the TV camera through small holes to do lobectomies. And we defined for a trial that we ran what we felt like would be the definition for this. And so it means it's totally anatomic, oncologic, and thoracoscopic. What that means is that you don't just staple across things in big masses, that you individually isolate the blood vessels and the bronchus and the lymph nodes and take them out one by one, just like you would do in an open procedure. However, you use only a small access incision that usually is about 4.5 centimeters. That's less than 2 inches or so. You don't use any retractors or rib spreading, which is really what causes the pain, putting the rib spreaders in. You take out the lymph nodes, and that you can't take out all the mediastinal lymph nodes at the same time. Here's a drawing of our approach, which shows someone from the right side, and we do it through 2 little incisions. The lower incision is for the camera, and the upper one's for the instrumentation. Now, we've done well over 1,000 now, but in our first 500, you can see that the duration of having a chest tube or a drainage tube in was only 3 days. The length of stay was around 3 days, which is our average. We had a very low conversion rate, which means you get in there and you just can't do it. And our mortality was very, very small at 1%, which is a fraction of what it is for patients who had an open procedure. We had no deaths in the operating room because initially people were saying this is not safe, and of course we've proven it to be quite safe. Comparing our thoracoscopic patients to those from that Z30 trial, which was the lymph node trial I just spoke about, the 1,000-patient trial, which was an open operation, in other words, with a regular thoracotomy and a rib spreading, you can see the length of stay, the chest tube, pretty much everything was less with the thoracoscopic approach in the same population of patients. In summary, I think we've shown a lot of advantages to the thoracoscopic lobectomy. If you have a very small incision, you don't use a rib spreader, there's certainly less pain and less analgesia or medicines required. You preserve pulmonary function because it doesn't hurt on your side. You're able to breathe more. We get people back to work in full activity. I have people playing golf and tennis at a week or 10 days. The length of stay in the hospital is less. There's lower complications. And more importantly for us, if the patients do well from this operation, let's say they do have some lymph nodes and are candidates to give chemotherapy after surgery, they can get it sooner. Because frankly, a lot of our patients who have thoracotomies, they're so debilitated after surgery that they can't get the chemotherapy on time. So we found that was also an advantage. Over the last 5 years, the robot has been introduced for thoracic surgery, and the robot has been used more in abdominal surgery, and so now there are a series of patients, up into the hundreds of centers that use the robot. The robot certainly allows you to control more instruments, and so these are these little teeny arms that fit into the chest. The surgeon actually sits at a separate console, and an associate surgeon is at the table with the robot. The camera is definitely better. It's about 10 times visualization, and it gives you stereoscopic vision, so it looks like you're looking through binoculars where you can see with both eyes. Whereas with the regular thoracoscope that I use most commonly, it's a flat TV screen, so it doesn't give you the depth perception that you get from the robot. The instruments are what we call wristed, so they move a whole lot more than our straight sticks that we use, more like chopsticks that we use in video surgery. And there are new instruments coming. The downside of the robot is the setup is much less flexible. It's a machine, and it's very cumbersome and fills up the entire operating room. There are no data that show that its outcomes are any better than a thoracoscopic, except for the fact it takes longer OR time. And the big problem is these robots cost about $1.5 million, and the use contract on them is about $100,000 per year. So Right now, I think that they may be useful in the future. There are centers that do a lot of those, and one of my partners does all of his lobectomies through the robot, but it certainly has not been shown to be any better than other minimally invasive approaches. In 2012, I mentioned that lobectomy is a standard operation. Well, what about patients who can't undergo a lobectomy? What if you have somebody with poor lung function or poor heart function or other issues that can't undergo that? Well, there really wasn't a defined population for this. We have all used smaller resections. We call them sub-lobar resections. And we also know from an old trial that if you take out less than a lobe, the chance of the cancer coming back locally goes from 4 to 5% in a lifetime to 20%, which is a significant increase. So one of our cooperative groups did a randomized phase 3 trial, which we just finished, where we looked at wedge resection using the TV camera with or without using brachytherapy. Now, brachytherapy are little seeds of radiation that you actually sow along the staple line. And the thought was that if you put this little bit of radiation right where you do the staple line, maybe you will decrease the risk or the rate of local recurrence. These were all patients who were not candidates for lobectomy, so they had strict criteria of bad pulmonary function, heart disease, on home oxygen. This is the scheme of the trial, showing the randomization. Arm 1 was just the resection. Arm 2 is the resection with brachytherapy. And the goal of this trial is to see if adding this little bit of radiation locally was going to improve survival. The trial has finished accrual, and it should have its events ready so that we will hear about it this year at ASCO in the spring. And so we look forward to seeing the results of this trial. A second trial that's undergoing right now is for the patients who have small tumors but have good pulmonary function. But the question is, for these very, very small tumors, tumors less than dime size, do you really need to take the whole lobe out? And this is analogous to doing a lumpectomy versus a mastectomy for breast cancer. And we know that a lumpectomy is appropriate for small breast tumors. And so this trial now has over half accrued. You can see it in the yellow there. There's almost 500 patients on it. And these patients are randomized to either a lobectomy or this limited resection called a segment, which I'm going to go more into in just a second. And what is a segmentectomy? Well, it was, again, described back in the 30s by Dr. Churchill and Dr. Belzy at Massachusetts General Hospital in Boston. It's sort of been a lost art until very recently. In the last 10 years, people rediscovered it as an option for very small tumors. And the difference between this and what we call a wedge resection, you just take a staple and take a chunk of lung. The segment actually allows you to get the lymph nodes, the blood vessels, and everything down in part of the lobe. And each lobe has a few segments, and by doing that, you get still an anatomic resection, but you leave a lot more lung. And I list here a bunch of the different segments that one can do on each side. There's about 3 or 4 on each side, and we hope this is going to be a useful operation. In summary, I've tried to give you a little overview of some of the things that we're doing in thoracic surgery so that we can improve the care of our patients with more localized lung cancer. And we've certainly been able to improve the accuracy of staging in patients for multiple different therapies. And I can't overemphasize that this is a team sport, lung cancer. It is the surgeon, it is the medical oncologist, the radiation oncologist, it is the pulmonologist, and it is the thoracic imagers. We all work together with our support teams to make sure that all the patients get the appropriate care. We've certainly, with these minimally invasive approaches, have been able to extend the indications and patients who are now candidates for resection. I very seldom have a patient who's not a candidate for a lung resection. Now, frankly, it's only people with ongoing coronary disease or bad congestive heart failure that we can't operate on, because we can take lung resections out of just about everybody now. And we've certainly been able to limit the morbidity and mortality with operative resections, so that as we move forward and get less and less invasive, hopefully we'll come up with ways of treating early-stage lung cancer so that patients survive, do well, and will be able to get back to productive life.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support.